Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 229 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, RMG, a 58-year-old man living with HIV developed sudden onset watery, non-bloody diarrhea. RMG was not taking antiretroviral therapy and had disengaged from services for 3 years. RMG sought medical help after the diarrhea had persisted for several weeks. RMG also reported malaise, anorexia and abdominal pain. On examination he was thin and his mucous membranes were dry. RMG had lost 10 kilograms in weight since his last recorded weight 3 years earlier. Investigations were done and the results were as follows. Eosinophil count was 0.7 times 10 power 9 per liter. The normal range is 0.04 to 0.40 times 10 power 9 per liter. His serum potassium was 2.8 millimoles per liter. The normal range is 3.5 to 4.9 millimoles per liter. His serum creatinine was 185 micromoles per liter. The normal range is 60 to 110 micromoles per liter. The baseline value was 74 micromoles per liter. His stool microscopy is shown in the photograph below. Elliptical 30 × 15 micrometers cysts were visualized using a modified Kinune stain. Pause the video and carefully scrutinize the photograph showing his stool microscopy before progressing to the next slide. So my question to you is, what complication is reported with this infection? Is it A. Acalculous cholecystitis, or B. keratoconjunctivitis, or C. myositis, or D. pancreatitis, or is it E. reactive arthritis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Acalculous cholecystitis. I will clarify why. Acalculous cholecystitis is recognized as a complication of infection with Cysticercospora belli. It is also recognized in infection of HIV patients with enterocytozoon BNUC and encephalitiszoon intestinalis. Cysticercospora belli causes self-limited watery diarrhea in the immunocompetent, but illness is more severe and more prolonged in immunocompromised patients. Diagnosis is usually made by detecting typical oocysts in feces, although acid-fast staining improves sensitivity above routine fecal microscopy. Please advance to the next question. And the next question reads, KLN, a 39-year-old woman presented with a painful right eye, describing a foreign body-like sensation and tearing. KLN wore soft contact lenses on a daily basis and admitted to poor practice, including showering while wearing her contact lenses, and wearing them for prolonged periods. KLN was otherwise well, and had no significant comorbidities. Examination was done as shown in photograph 1. A corneal scraping was taken as shown in photograph 2. Pause the video and scrutinize these two photos before proceeding to the next slide. So my question to you is, what is the most likely causative organism? Is it A. Acanthamoeba species, or B. Balamuthia mandrillaris, or C. Encephalitozoon helum, or D. Naegleria fowleri, or is it E. Sapenia pedata? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Acanthamoeba species. I will explain. Acanthamoeba keratitis, abbreviated as AK, is an infection of the cornea typically associated with contact lens wear. The hallmark of acanthamoeba keratitis is severe ocular pain, photophobia, and a central or paracentral 360 degrees stromal ring infiltrate. Corneal scrapings may reveal trophozoites and cysts of acanthamoeba species infiltrated between the lamellae of the cornea. Please proceed to the next question. And the next question reads, SKH, a 54-year-old farmer in Massachusetts, became acutely unwell in late August. SKH had nonspecific symptoms which came on gradually for 1 week, including fatigue, anorexia and headache. SKH then developed high sustained fevers, sweats, myalgia and dark urine. SKH's medical history included splenectomy following a road traffic accident 15 years earlier, hypercholesterolemia and hypertension. SKH was up to date with his immunizations and took amlodipine and atorvastatin. SKH had not traveled outside of the USA in the preceding 10 years, and had not left Massachusetts in the preceding 6 months. SKH lived with his wife and 2 teenage daughters, all of whom were well. On examination, SKH was visibly icteric with pale conjunctivae, and was dyspneic at rest. SKH's body temperature was 38.5 degrees Celsius. His heart rate was 124 beats per minute, and his blood pressure was 85 systolic 50 diastolic. His respiratory rate was 34 breaths per minute. SKH had inspiratory crackles to midzones bilaterally. SKH's liver was palpable 2 cm below the right costal margin, and his spleen tip was also palpable. Investigations were done and the results were as follows. HIV-AG-AB was negative. Hepatitis C-IG, was negative. HBs was negative. Hemoglobin was 63 grams per liter. The normal range is 130 to 180 grams per liter. White blood cell count was 17.6 times 10 power 9 per liter. Neutrophil count was 14.3 times 10 power 9 per liter. Platelet count was 112 times 10 power 9 per liter. His serum creatinine was 213 micromoles per liter. The normal range is 60 to 110 micromoles per liter. His serum alkaline phosphatase was 167 units per liter. The normal range is 45 to 105 units per liter. His blood film is shown in the photograph in the next slide. Pause the video and carefully scrutinize this photo showing his blood film before proceeding to the next slide. So my question to you is, what is the most appropriate treatment? Is it A. Atovaquone plus azithromycin, or B. Atovaquone plus proguanil, or C. chloroquine plus primaquine, or D. quinine sulfate plus clindamycin? Or is it E. sulfadiazine plus pyrimethamine? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. Quinine sulfate plus clindamycin. I will justify why. In asplenic patients, infection with Babesia microti can be severe, with intense hemolysis leading to severe anemia, jaundice and renal failure. DIC, ARDS and non-cardiac pulmonary edema are described. Diagnosis is by microscopic examination of a Giemsa-stained thin blood film. The blood film, in the photograph above, shows a typical tetrad of merozoites within an erythrocyte Maltese cross, as well as multiple ring forms. First-line treatment for severe babesiosis or infection in immunosuppressed patients is with quinine and clindamycin. Treatment is recommended for at least 6 weeks. Blood transfusion and intensive care support may be required. Please proceed to the next question. And the next question reads, TFT, a 72-year-old Chinese man presented with fatigue, abdominal discomfort, anorexia, weight loss of 6 kilograms, and diarrhea for 2 months. TFT had been born and brought up in Guangdong province of China, and had emigrated 5 years previously to live with his daughter after she married. Stool microscopy for ova, cysts and parasites showed scanty oval eggs, 30 by 15 micrometers in size, with a terminal spine seen. Pause the video and scrutinize the photo before advancing to the next slide. So my question to you is, what malignancy is associated with this infection? Is it A. cholangiocarcinoma, or B. gastric carcinoma, or C. gastrointestinal stromal tumor, or D. hepatocellular carcinoma, or is it E. malt lymphoma? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. cholangiocarcinoma. I will clarify why. Cholangiocarcinoma is a recognized complication of Clonorchis sinensis infection. There may be an association with the consumption of carcinogenic nitrosamines. Please advance to the next question. And the next question reads, JHD, a 57-year-old Japanese man presented with a one-day history of severe headache, fevers and photophobia. JHD had also had intermittent abdominal pains and diarrhea for the preceding month. On examination, his body temperature was 38.1 degrees Celsius. He had a heart rate of 110 beats per minute, and a blood pressure of 102 systolic 60 diastolic. JHD was drowsy but rousable. Respiratory examination demonstrated a moderate left-sided pleural effusion and scattered crackles. JHD's abdomen was soft, mildly distended but non-tender. JHD had bilateral ankle edema. There was no focal neurology. His investigation results were as follows. Neutrophils were 16.4 times 10 power 9 per liter. The normal range is 1.5 to 7.0 times 10 power 9 per liter. Eosinophils were 0.3 times 10 power 9 per liter. The normal range is 0.04 to 0.40 times 10 power 9 per liter. His CRP was 252 mg per liter. The normal value is below 10 mg per liter. His albumin was 24 grams per liter. Alkaline phosphatase was 96 units per liter. The normal range is 45 to 105 units per liter. ALT was 34 units per liter. The normal range is 5 to 35 units per liter. His CSF opening pressure was 260 mm of water. The normal range is 120 to 250 millimeters of water. Protein was 0.92 grams per liter. The normal range is 0.15 to 0.45 grams per liter. Glucose was 0.2 millimoles per liter. White cells were 350 per microliter. The normal value is equal to or less than 5, with 90% polymorphs. His gram stain showed gram-negative rods. His X-ray of the chest showed pleural effusion to midzone on left. There were scattered bilateral pulmonary infiltrates throughout. So my question to you is, what is the most likely underlying pathology? Is it A. alcoholism, or B. deferoxamine therapy also known as desferrioxamine, or C. diabetic ketoacidosis, or D. infection with HIV-1 virus, or is it E. infection with Strongyloides stercoralis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is E. infection with Strongyloides stercoralis. I will explain why. This is a case of hyperinfection with Strongyloides stercoralis. Immunocompromised individuals are at risk of cycles of autoinfection leading to rapidly increasing parasite burden. Gram-negative bacteremias and subsequent seeding to other organs result from the falciform larvae crossing the intestinal wall in great numbers. Complications such as gram-negative meningitis are well recognized. Given his ethnic origins, this man is probably infected with HTLV-1, which is a significant risk factor for disseminated strongyloidiasis. Please proceed to the next question. And the next question reads, GDD, a 34-year-old woman presented with migratory swellings over her right arm and back. They typically lasted for 1 to 3 days, and were hot, red, painful and itchy. GDD had returned 4 weeks earlier from a 12-month job in Cameroon. A presumptive diagnosis of liasis was made, pending investigations. So my question to you is, what was the most likely vector for GDD's infection? Was it A. Anopheles mosquito, or B. Chrysops deerfly, or C. Culex mosquito, or D. Mansonia mosquito, or was it E. Simulium blackfly? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Chrysops deerfly. I will clarify why. This is the vector responsible for the transmission of loa, with the female of the species biting during the day, especially in the wet season. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 230.